when you go into panic, and actually panic, but your body's going into panic and things like that, the norepinephrine content is so high, it causes inappropriate storage and retrieval in the hippocampal area. I'm taking a 2-day course, I'm going to do it in an hour and a half, so you're not going to get the whole thing.
There's constant vigilance.
Excuse me?
Constant vigilance.
Well, it's one of the aspects of it. So, how does this quickly work? I'm going to draw this over here. Potentiate. Now, here's what it is. And this is what took forever to learn. This is what took 8 years of research. You're going to learn in 2 minutes. Yeah, right with the pointer. Thalamus goes to the amygdala. And I'm going to draw now. These are neurons that come from the thalamus to the amygdala, and this area is the postsynaptic membrane of that neuronal cell. If you can imagine, it looks like a little pillow, a cell that looks like a little pillow. And what happens when a UFS is generated through the thalamus? It creates 100 hertz tetanus in the amygdala and causes activation of an AMPA receptor. An AMPA receptor is a tissue that rests on top and in the cell that allows for more rapid transduction of the electrical stimulation. So it moves along quicker than it would normally be if it didn't have it. That's why these things are so stimulatory. And then what was really amazing, what we discovered was this tetanic event of 100 hertz causes the production of something called protein kinase M zeta. And it's all in the article that you read. Protein kinase M zeta is an RNA. It then, at activation, produces a chemical that permanently phosphorylates and keeps permanent this AMPA receptor on the amygdala forever. And the interesting part about that is that protein kinase M zeta has no regulatory domain to shut it off. So it just stays on all the time, and that's why everybody is always stimulated once you're chronically or traumatically encoded.
It's a very interesting EEG confirmation of this. 100 hertz is in the gamma range, which is way, way at the top of the ordinary brainwave ranges. And when you're doing EEG and you get close to a traumatic memory, you will see the spindles of gamma rushing through the brain. They're like kindling. And they're right there. There's no mystery about it.
Well, you see, but my belief, by the way, in all of this is that the cortical area is the affect of the limbic system, which is the effect. So we're taking this down. That's why we can move these things along in minutes, which we're going to do right here with you. So does everybody understand this now? So now we have a circumstance that electrochemical stimuli enter the thalamus. If it's perceived as a UFS, an unconditioned fear stimuli, it causes 100 hertz tetanus, which permanently stabilizes an AMPA receptor on that neuron, because from an evolutionary standpoint, we got to remember these things forever, and we got to remember them all the time. Now, how do we get rid of it? What are the consequences of this? And now I'm moving along as quickly as I can. Everybody following me so far? Because this is not easy stuff. So, mechanism of traumatization. Stimulus, unimodal, and UFS passes the thalamus, signal to the amygdala, fear and defensive rage generated, increase in norepinephrine and cortisol in the amygdala, inhibition in the medial prefrontal cortex, complex content and context enter the amygdala, the 4 requirements are met, AMPA glutamate receptors in the BLC amygdala are potentiated, BLC modulates binding of the components, remember, cognitive, somatic, autonomic, and a traumatic memory is stored. It looks like this. Just quickly. Sensory input, electrical, chemical transduction, thalamus, emotional stimulants, AMPAR receptor activated. This is in the lateral nucleus. The cortex comes in either directly or via the hippocampus, either inhibits this or activates it, and then it binds the emotional, somatic, sensitive, cognitive, can you speak quicker, and autonomic aspects of this. Now, I'm going to grab this chair. I'm moving as long as I feel. Is this interesting to you guys?
Yes. Great.
Very good. Take your time.
Okay. You know, when you come up here, and we've never met, right?
Right.
Okay.
Yeah.
What I'm going to do, I'm putting it on the line, is I'm going to, once I see what Kate's problem is, or concern is, I'm going to make it go away in 10 minutes, right in front of you. Now, what? Well, I appreciate your intellectual braveness. So, I hope this works. And the reason why I'm doing this, we're not going to really, and if we have time, there's a thing called self-havening. This is facilitated havening I'm doing here, where I'm actually going to touch her. But if before the end of today, if we have enough time, each one of you is going to treat yourself in a term called self-havening. And
We should definitely do that.
okay, well, we'll do that. Well, if we have, look, does anyone have a rush to go anywhere yet?
No.
Okay, so I'm going to slow down a little bit. Let me get a glass of water. What?
You want to tell us a traumatic event?
I feel better.
One
I'm
second.
less traumatized now since you've slowed down.
What? I didn't hear what you said.
I'm less traumatized now since you've slowed down.
Oh, good. So I can't speak that fast for that long. Part of this approach, or in fact, the most important part of this approach is taking a good history, which you all know how to do. Except now we're going to look at history from a different perspective. Neurofeedback people really don't need much history, do you? Do you need much history, or?
Yeah.
You do, okay. So what we look for when we do the history is what the initial event was. Can you remember when you first had this feeling?
Mm-hmm.
Do you remember the event?
Mm-hmm.
Do you remember it clearly?
Yes.
Why does she remember that? How long ago was that?
Well, it's more like continuous event.
Yes.
It was a bit like over a long period of time.
And what was that event? Would you mind sharing?
Yeah, we're about to get a whole lot closer. I was diagnosed with PTSD from an abusive relationship.
From a what?
Abusive relationship.
Okay. And you can bring up your feelings and your anger about that abusive relationship.
Mm-hmm.
Okay. We're going to make this go away right in front of your eyes. So now this was a pretty quick history. I probably would do a little bit more extensive history. But I've done this enough times, so hopefully I'll get it right. So once we generate a history, I'm then going to ask Kate in a few minutes, a few seconds, to go back and bring up all of your anger about this event, and bring back your emotional components, your autonomic components, your other components, just your somatosensory components, everything, every sight, every smell, all your senses, try to apply that. And then I'm going to ask you to give me a reading on a scale from 1 to 10. What's it called? An SUD, subjective unit of distress, right? Right. And I'm going to ask you to give me a subjective unit of distress, and hopefully 10 being you're really in that moment, 0 being the absence of that moment.
Okay.
Okay? And then I'm going to apply havening technique, which you'll observe, and distraction techniques. And then I'll explain after we finish this, how it all works, and then we'll have any questions and answers. You ready?
Okay.
I want you to face me a little bit. Great. What I like you to do is close your eyes. And I want you to really get pissed at this relationship. I want you to bring all those fights and all those angers and all the abandonment feelings, all of them into your mind until such time it's as present as it absolutely can. I'll give you 30 seconds to do so. Go ahead. Okay, Kate, I want you to write the number from 1 to 10 on this piece. Open your eyes. Write the number from 1 to 10 on this piece. 7. Okay, close your eyes. From this point on, I just want you to listen to the sound of my voice and do as I say, okay? I want you to start humming Old MacDonald Had a Farm. Good. I want you to count from 20 down to 0. Let's do it from 1 to 20. And each time I want you to walk up a step. And with each step causes you to feel more relaxed. And when you get to the top of that stairs, you will see a beautiful vista of your own making. Or out loud.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
Good. Open your eyes and look at my finger. Hold it, please. Close your eyes, look at the back of your eyelids. Count backwards from 5 to 1 out loud.
5, 4, 3, 2, 1.
Good. Place your hands on your lap, your palms up. Take 3 deep breaths. Good. Doing good, please. I want you to place your hands like you're praying. Good. Good. I want you to take me out to the board. Allow your shoulders to relax. Good. Count backwards from 30 out loud by threes.
30, 27, 24, 21,
Beautiful.
18,
Beautiful.
15, 12,
Good.
9, 6, 3,
Look at your eyes, look right from there. Close your eyes, look back to your eyelids, take a deep breath. Good. Put your hands on your lap. Take 3 breaths through the nose. 40 by 4s. Okay.
40,
Good.
46.
No, count backwards from 40 by 4s.
Oh. That's like
40.
40, 36,
2.
32, 28, 24, 20, 16, 12, 8, 4, 0.
Come on, come on. Look at the back here. Take a deep breath. Count backwards from 5 to 1.
5, 4, 3, 2.
Put your arms on your lap, with your arms up. Take 3 deep breaths. Just rest for a second. Whenever you're ready, open your eyes and write the numbers you're feeling now. One, close your eyes. Take a deep breath. Mary had a little lamb. Wrap your shoulders to your legs. And just let it go. Good. Count backwards from 50 by 5s.
50, 45, 40, 45, 30, 25, 20, 15, 10, 5, 4.
Good. Take a deep breath. Give yourself a gentle squeeze. A little love and hug. Good. Good. Put your hands on your lap with your palms up. Take 3 deep breaths. Rest for a second. Whenever you're ready, open your eyes and write the number. It's a 1, 2.
It's a 1/2.
Oh, it's a 1/2? Okay, let's go see if you can let it go. I want you to just let it go. Give yourself a gentle hug. Take a deep breath. Take me out to the ball game again. Relax your shoulders. Just let it go. It's okay.
Okay.
Okay, just close your eyes for a moment. Close your eyes for a moment. I'm now going to tell you what she's going to tell you. 4 things happen. Either, one, she won't be able to recall events. They'll appear as she's looking at them from above. She won't be able to see them. There'll be something in the way, but the emotion kind of will become. Okay, open your eyes. Thank you. First of all, how do you feel?
Very relaxed.
Very relaxed.
Very relaxed.
Like you just had a couple of glasses of wine.
Yeah.
Okay, that's great. So what I'd like you to do is, when I tell you to close your eyes and see what memory you have and how it stimulates you as compared to when we started, and what the memory looks like. So close your eyes and try to generate that memory.
I can't.
Okay, how do you see it?
I can't even see what he looks like.
It's gone.
It's like that there's a cloud in my head. Like I literally can't remember what he looks like right now.
Can't
It's just
remember.
very weird.
Very weird.
Yeah. It's a little unnerving right now.
Okay. But do you feel relaxed? And by the way,
Yeah, no,
your post,
I
your
feel
PT
that this is positive.
your PTSD is gone now. Forever.
You think so? That would be lovely.
So, does anyone now want to have any questions?
What were the consequences, Kate, for you of the traumatic memory in your daily life?
Lots of intrusive thoughts, and intrusive thoughts that I feel like driving, and then go back to that one of the many moments, and then end up somewhere I don't know where.
And did it affect the relationships, ability to
Yeah,
be with men?
absolutely. I'm incredibly afraid.
Did it matter when they
Chill. Like I just smoked some weed or something.
It's not that I do that.
Just so you know, if the body bears the burden, I would suspect you would feel lighter.
Yeah, like my hands were getting real clammy when you told me about it. Like when you told me to visualize it, and it was weird. Like
Sympathetic response.
yeah, like and my face is warm now, but during it, like I got a very cool feeling, and now I'm getting like blood pressure back.
Okay, close your eyes again. See if you can remember anything from those things.
The second one. It's foggy, but it's always physiological or emotional response. And we're not just like, like I think I've seen a bag of chips like that. Thank you.
Let's have a round of
Oh, you tested my math skills and my.
So that's permanent, is it permanent?
Permanent, by the way, permanent. We removed the little phosphorus ion from the power center. Does anyone have any questions? Doesn't this blow your mind?
Could this work for something that happened, like something like the person like cannot remember,
Yes,
like late,
early.
early?
Under 5, you have to go with the felt sense. Treat the felt sense.
So,
Then the question is, how does it happen?
Excuse me?
How happened?
How does it happen?
Yes.
I'm going to show you in about 2 minutes.
Question, what was the purpose of stressing her with the man?
Say that again?
To me, I saw the counting, stressful.
Oh, it's distraction. We'll discuss. I'm going to show you. Next stop is disrupting the traumatization. I just wanted to.
I see.
So in the video, it looked like you had done the round of what you were doing, the touching and the humming one time. I mean, you did that several times with her. Is that because
No, but I usually do a sequence of 3.
you usually do 3 or 4? Okay.
Well, or until she gets to 0.
Does
You have to get it to 0.
Okay, so that's the expectation.
And what was interesting about this issue, and Ms. Fisher related to it in her articles, is that there is a part of her identity of her life as a traumatized person, almost as a victim. And why she went to a half where she was a little bit reluctant to let that part of her personality go, but eventually, is that somewhat true?
That's absolutely right, like it was still, I didn't wanna tell you zero, like I wanted to be honest, you know, cause it was
You didn't wanna
still
let it go.
there,
Right,
you know?
and so, you're right. So,
Thanks to know.
I'm thinking about sexual trauma.
treated many hundreds.
But when I do neurofeedback, it'll be 2 sessions just before just getting used to, I'm a male, and if I'm treating a female, it would take 2 sessions, I'm going to be putting my hands in you, we're going to be touching your body.
You know the cool part about this is, you don't have to touch them. You want me to show you today how to do it? This is facilitated dating. Now, facilitated dating is a little different than self-dating. It's more powerful. It's like you trying to tickle you or you trying to tickle yourself. So you have an option as a therapist, depending upon the presentation, especially with sexually abused people because they have this issue about touching, they can touch themselves under your guidance. But how long would this take in neurofeedback therapy? This took 10 minutes. I just throw it out there.
What have you found in terms of how long these results last?
Permanent.
But by the way, do you, if you close the eyes and you're touching her, can you have a picture of mother hugging her or touching her? Or say a deity like Jesus hugging her?
Here's the story. Well, let me just go into how all this works.
Yeah,
And then
okay.
we have some discussions after that. How's that sound?
Yeah,
How are we doing so far?
Great.
Everybody engaged? Okay. I'll just quickly talk about phobias, then we'll go into disrupting and traumatization.
You don't want this.
No, I'm good. Let me just get a drink of water. Kate, mwah, you were great. And I'm so, first, so thank you so much. And I think you will now, and what I'd like you to do over the next few days, if there's a website, is there a website that she can communicate how she's feeling a couple of days from now?
We'll make it happen.
Yeah.
It's gonna
She's
be
at
a,
my
Figure it
office
out.
every Wednesday,
It's gonna
so
be
I
a-
will have her go and sit and go on the, she can do it there.
it'll be a private Yahoo group,
Okay,
so nobody else would see it.
Right, just for this group.
the Kate report.
You know what, you know, in a few days, write a little letter of your experience before and that experience within a few days, and say what changes have had, then send it to Sue, wherever, and then the rest of the people in this group can see what happens.
So you only do one treatment of this, you don't do multiple?
Well, once you're at zero, unless you have some other issues you want to discuss.
So each issue is a separate detraumatization.
You know, yes and no. What we are relatively early in this process. What we're finding in some of our cases that you can bundle anger in, do a little bundling if there are multiple things. We seem to be getting pretty good results with that. So we're looking now into concepts of bundling things, but in general, each emotional trauma that's encoded is encoded on a separate neuron in the amygdala, and you need to treat them separately. So if a person has a snake phobia and an elevator phobia, you want to treat them separately.
What do you do if the person was traumatized before the age of 5, give or take?
I would say the felt sense.
What do you mean
by
by
the felt sense of?
I'm not sure what that means. What's that?
There, for those people who have experience with people who have traumatic experience, child abuse under the age of 5, before the hippocampus comes on, which is declarative memory, these memories are stored, but they are stored in amygdaloid areas around there, but they do have a felt sense about it, and you treat the felt sense.
What does havening mean?
It means, well, you're gonna find out now.
Oh,
It means to find a safe place, because from a neurobiological standpoint, if an animal escapes a predator, how does the body downregulate the high norepinephrine, high dopamine from escaping? It produces serotonin. And so therefore, it is the neurobiological equivalent to finding a safe place. So hence the term havening.
I noticed you.
Oh, we also call it now we're calling it amygdala depotentiation therapy, just for the scientific people of the world.
Now what if Kate meets her boyfriend again?
She'll have no response.
Can she go like that?
She'll have no, she can't, she can't, at this point, is this true, Kate can't remember what his face looks like?
Well, right now it's very cloudy. When I was sitting there, I could not.
Well, can you remember his face? How do you bring his face up?
So it's like fog.
Okay. And you feel totally different.
I feel very relaxed.
Good.
But if she ran into him, she'd recognize him, right?
Well, she'll recognize him, but she'll have no response. Oh, hi. How was soup?
So you don't have sometimes people coming back to you and saying, that really did seem to help me, but I'd like another treatment?
Yes. There are times in which there are layers of trauma. And sometimes on really severe traumas, we have to have maybe, the most we've ever done was 5 or 6. And that's taking an Iraqi war veteran who was totally incapable and just bringing him back to health, which we have on video, done by a documentarian.
Have you had any experience with this method with other health problems?
That's such an interesting, great question. Every health problem that exists, from my point of view, is based on the fact that the affect of the underlying activated AMPA receptors creates a physiologic response which creates the problem. So pelvic floor dysfunction, somatic pain, unwanted emotions, grief, immune function disorders. I could go on forever. We have 4,000 patients treated of things that you can't even imagine.
Have you found patterns?
Excuse me?
Have you found patterns associated?
Everybody is so different. Everybody's experience. And when you see this, it's so many people, this is an endless market, by the way.
Yeah.
For those people who are looking to expand their practice, endless market.
So I'm thinking of like a cancer patient.
Speak up.
We work with cancer patients and.
Well, what a wonderful idea. We do that.
Yeah.
What we do is, a big problem with cancer patients is emotional trauma due to fear of recurrence.
Yeah, right.
Oh, yeah.
Oh.
Yeah, anxiety.
Yeah.
Wow.
Or even getting there.
Wow. Good idea.
How young of a child have you worked with doing this technique?
Well, my feeling is it makes no difference. I've worked with 7. What's interesting is that a major portion of traumatization occurs between the ages of 6 and 12. And, divorce, traumatization to the child, alcoholic parents, abandonment, a lot of, and these things are deeply encoded, which just like the very first chart that I showed you, has consequences down the road. It kindles future traumatization. And we go back, take a ride out, done.
So if he has future traumas, then again,
Excuse me?
if he has traumas in the future, you have to treat him again.
Well, actually, the truth is, in our treatments, we teach them how to self-treat. So they, after a while, they'll go out and treat themselves, which we'll talk about.
I noticed you're very gentle in your touch, very comforting and all that. You also use
Go ahead, I'll show you that.
EMDR. And
Well, that EMDR, now, EMDR is very interesting.
Stroking and, in other words, there's a combination of techniques which I like, and they're all those kind of somatic deconditioning sorts of techniques.
Psychosensory therapies.
By the way, for a psychologist to be able to touch a patient, here's how you solve that with biofeedback. If you don't do this, you can be accused in a law case of assault or battery. You just ask the person if you can.
Well, I don't have it, but in my book, which I recommend everybody get, because look, you're getting 8 years of, and Susan will tell you, this is a 2-day presentation I'm giving to you in about 10 minutes, so there's a lot more stuff there that I'm just not covering.
Do you have it all out, the whole thing step by step in your book?
Everything that I'm telling you, except for about the AMPA receptors, is that we worked out within since the book was published, but in the second edition it will be there. You want to just take that little thing off here? So we're going to go into a quick understanding of quick 2-minute understanding of phobias. So we have an unconditioned stimulus called height. You know, stepping off an edge of a cliff, the brain says, not so fast. Fear. The conditioned stimulus, the bridge. Fear. Traumatic memory consolidation, and then retrieval of memory when you go over another bridge. Fear, and then it generalizes to all bridges. That's how phobias go. Now, these things become much more complex than you. I was telling you the story. I forgot I was telling someone the story about a patient, a 16-year-old came to me by his parents, he's a bipolar child, referred to me by a pediatrician. He said the child has a needle phobia, and his parents want to send him to Israel on birthright, and unless he gets this shot, he can't go. So I said, my child, 16 years old, dentist, you know, what do I, you know, you can get my thumb strung up by the state education department. But I said, okay, because I knew the pediatrician very well. So he comes in, 15 minutes later, no problem, handling needles, no problem, blah, 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 blah. I said, okay, why don't you now go to your doctor, get a shot? Goes, father calls me up next day, won't get in the car. Wow, that's interesting. And as Ms. Fisher would state, that it really wasn't only the fear of the needles, but it was also additionally the fear of being abandoned and moving into a new place that was causing him his distress. So there was a layer there. So I said, bring it back again. Brings it back, and father comes into the office, says, won't get out of the car. I go, okay, would you mind if I went over to the car? He says, he won't roll down the window. I said, I don't, these are true story. He said, I don't need him to roll down the window. So I go to the car, I go, how are you, blah, blah, blah. I heard you're having a challenge in getting this done. And I know covert hypnosis, I know neuro-linguistic programming, so and other nifty little tricks, so I started to chat to him. And I realized at that time that he was struggling between his two voices, his bipolarity. I'm scared to death and I don't want to be abandoned, I want to go. I'm scared to death, I can't, and he couldn't resolve that. And at the end of the day, I did a quick, he finally opened the window, and I just did a little touch on the arm to produce serotonin and said to him, remember, always choose the voice that moves you forward. And I said, have a nice day. And I said to his parents, okay, take him to the doc. So he drives to the doc's office, sits in the doctor's office for 3 hours with his brain going, I'm going, I can't go, I'm going, I can't go. Had the shot, went to Israel. And at that, for this child, it was a seminal event that will change his life forever, that he chose this path.
That's right.
How wonderful. 15 minutes. Very cost effective. Does everybody understand this? You guys are really, Susan, you're right, they really are pretty smart. Disrupting and traumatization. All right, so we're going to talk about havening. We have about another 10 minutes to go, and we'll have some questions. Havening has 3 components. Recall and activation of the emotional core. It is vital that we activate this particular postsynaptic neuron that's associated with this problem. So postsynaptic neuron is associated, the phosphorus is sitting there, and the brain is activated. We then apply distraction techniques. Now, what's the purpose of distraction techniques? The purpose of distraction techniques is to get the thought out of working memory. Now, what is working memory? What is working memory? Working memory, I'm sure you all know these things. Working memory is a place in your cortex that you bring concepts to apply applications to. So it's that area that you think. But the thing about working memory is that it can only hold one thought at a time. So if you were to try to hum and add 2 3-digit numbers together at the same time, you can't do it. because the working memory aspect only has a limited aspect of it. And what we recall, just like we recall, Kate, is this right? You recall the conscious and subconscious feelings, the autonomic aspect of you sweating and things like that, the somatosensory, how you felt in your system, and the emotional components. So that's how we bring these things up to be fully activated. So displacement of thought from working memory by distraction, humming a tune, counting, visualize movements. You saw me do all of those things. It makes no difference in which order you do them. But from my point of view, in my experience and where I do this, I run a system of counting, humming, touching, eye movement, and I don't care which order I do it in. So it's really unimportant, so there's no particular best way.
So while they're doing the humming and the counting and stuff, are they still supposed to be trying to recall the trauma?
No, you can't.
Just
You can't.
initially bring it up.
The thought is being displaced out of working memory.
Okay, so you initially bring up the trauma.
You're activating
but
that
then-
neuronal connection.
And they don't need to keep thinking about that.
They can't, well, we want, here's what's happening. Actually, I can show you the way. That's such a good question. All right, here's what's happening. Here we go. Okay. This is working memory. It's controlled by a central executive. It has a phonological group, which is a verbal commands.
Page 8.
Excuse me?
I'm just telling them where this is.
And a visual spatial sketch pad, which gives orientation. So once the trauma goes into working memory, what you want to do is displace it out of working memory, even though what we've done is here's the postsynaptic neuron in the amygdala, and here's the AMPA receptor, and here's the phosphorus ion, and this is the thalamus into here. We want this activated. And then by doing working memory, we take the emotional trauma off the table, leaving the activated AMPA postsynaptic receptor in place. Does everybody get that?
So even though they're not consciously thinking about it, their body's remembering it.
Yes, but this is still activated. Okay?
So it's almost as if you're bringing it up to and then it's like a target. You bring up the target and then you shoot.
Right. So, effective stimulation of areas. Now, this is right up your alley. Delta wave power generated is multiple of resting state. 90 times by touching the cheek. Now, we're going to talk about delta waves are important in a second. Shoulders, 5 to 38 times. Palms of hands, 5 times. Back of the hands, 1.1 times. Knee, vibrating calves and things. Just like your stim things you have here. Lateral eye movements, gamma point. You know what a gamma point is?
No.
Gamma point is in EFT and EMDR and these type of things. Totally unnecessary. This was something from Roger Callahan that goes back, but when this all comes out, when you read the book, totally necessary, and it only activates at 1/10 of 1% over baseline. And meridian points versus non-meridian points doesn't do anything. Now, the EFT people will be screaming down my throat about these things, but you know, we have this, and what's interesting, I have here the article. Where are you? Because you'll like this article. This is right up your alley, you guys. Here it is. This is by a guy named Mel Harper in the Journal of Traumatology not too long ago, on the neural basis of EMDR therapy, insights from QEEG studies. Oh, you know QEEG studies.
Bill, remember, it's a journal of
Traumatology, and yeah, I'll leave it up here if people want to look at it.
Dr. Ruden, could I ask you just to go back to your flip chart?
Say this again.
Could you just come back to the flip chart drawing for
Which one?
1 second? This one right here.
Okay.
And as you explained that process, you said you wanted to leave the activated receptor in place because?
We're going to show you.
Okay.
So, just quickly, let's see. What happens, stimulus comes in, AMPA receptor internalized, lateral nucleus in the lateral nucleus of the amygdala, the emotional, somatosensory, autonomic, cognitive things gone. How does this work? Deep attention, here it is, boys and girls. This is what took 8 friggin' years to figure out.
A good investment of your time.
Activation of post-synaptic neuron by recall. Got that? Low frequency waves opens calcium channels in activated neurons. The delta wave, along with GABA, which is produced by the presence of serotonin, which is produced by the presence of light touch. This activates calcium neuron, which is an enzyme for which the AMPA receptor is the critical substrate. Parts of the AMPA receptor are dephosphorylated. It causes a depotentiation or an internalization of the AMPA receptor. Removal from the surface and thus no longer able to transmit receptor is depotentiated. Calcium inhibitors, by the way, when they tested this, blocks this effect. And time courses in minutes consistent with that resonance. So what happens is, during this process, the delta wave, or GABA, caused by the serotonin goes like this. You're gone. Causes the AMPA receptor to depotentiate and internalize, causing the transmission of this event to be blocked, to become then a declarative memory with no ability to stimulate a physiological response. Does everybody get that?
Can I give you a metaphor as an artist for this? Okay, so I have this brush, okay, and it has these really sharp bristles, but there are these little plastic points on them that prevent it from scratching my scalp. So it's sort of like if I don't have those, it's going to make me bleed. But if I have them, it's going to brush my hair. So it's useful and declarative rather than painful and inducing suffering. So I just thought of that, like looking at this, because those are those little amperes, like going like this, and they wake up. When you get re-trauma, when you think of the memory, they wake up. But if now they're all blocked, they can't wake up. They can't transmit. They're blocked.
Right. Well, they're not there.
Yeah.
They're gone.
It's really weird that you just said that because I just leaned over to Mary Jo and I was like, I just feel like blocked right now. Like
You feel like what?
Blocked. Like I feel I'm
I think you're sitting there trying to recall the
I'm trying
memory.
to test this out, so I'm like, okay, let me see if I can actually like try and remember something. And it's like there's two pieces of me, the mind and then my brain right now. My mind is trying to go there, but my brain is not allowing it to do so. Does that make sense?
Yeah. Are you okay with that?
She's so Kate's trying to figure this out.
Yeah,
Believe me,
I am.
the post-treatment sequence of these things is people go,
That's exactly what I was just like.
okay,
And I'm
where
wondering,
is it?
okay, how long is this gonna last? Like,
It's gone forever. It's gone forever.
She's got a journal for us all.
This picture, I'm thinking about
This?
neurofeedback people I've talked to are always talking about attractors. That are attracting energy and then breaking up those attractors.
Neurofeedback works on the cortical level. My view of the way all of this works is that the cortical level is the affect of the effect of the limbic system. So that's why it takes so much longer, because you have to have learning in biofeedback, which requires protein synthesis, which takes a period of time. That's why sometimes your treatments are more elongated than something like this.
Well, I'm thinking about just that what neurofeedback does is provoke a challenge to the system.
Unless the emotional component of the issue is activated, it's too generalized, just like massage therapy or yoga or biofeedback or Reiki. Unless you are actually dealing with the specific phosphorylated, intercalated neuron in the amygdala, there's no effect because it doesn't depotentiate.
Does the amygdala ever thank you?
Yeah, it helps you be healthier and helps you live a more normal, healthy life. It really does thank you because it downregulates your stress axis, improves your immune system, it prevents vigilant behavior, it helps you be normal in relationships, it reduces somatic pain. We cure people with chronic pain for 50 years in minutes because it's centrally mediated. A lot of pain's centrally mediated. You know, you take all these car accident people who have back pain, you cure them in minutes. I had a guy, just quick story, dear friend of mine, comes to my house for dinner one night, he's like this. And we're having dinner, he's eating like this. I go, what the frick is going on with you? And he says, I've been to 5 doctors, I can't move my arms. I go, really? He's noticed. I go, really? I said, how would you like me to make it go away after dinner? Because I want to watch you eat like that. Not that it was pretty cruel or anything, but he said, sure. But I just happened to know a little bit of information about this because I was a friend. And he was engaged in a car accident. And what happened was, because of the 4 events, event, meaning, landscape, inescapability, he was suffering from post-traumatic stress disorder. And what happened during the car event, he gripped the steering wheel so hard, he blew out all the lactic acid in his arms. And that was co-encoded at the time of the traumatization as a somatosensory aspect of it. Got it? Good. So I bring him into my living room, and since I said, do you remember the car accident? He says, yeah, man, I remember that car accident. I said, well, why don't you bring it up, and we'll see if we can make your arms move. Whoop, 5 minutes later, whoop, whoop. Because he was suffering from post-traumatic stress disorder that was exhibited as it was at the time of the encoding. His blue, and that's why he couldn't move his arms. Amazing, right? Can I make this stuff up? Can you make this stuff up? I'm not going to get into hypnosis. I'm a hypnotherapist, but I'm not going to get into it.
We're 45 minutes off our schedule, so.
Okay.
And people may need a little break, and we're.
Well, I'll have it this. Let's give them a 5-minute break, and then I'm going to haven everybody in this room.
How long will your self-haven
Let me see how many more slides I have. Everybody understand? Oh, this is the last slide. And then you'll take a break and everybody come back and I'll haven
And
everybody.
how long will that take?
5 minutes?
5 minutes? Because what we'll do is we'll decrease our panel time if that's okay, because people stay here to be on this panel also.
We started later.
We did.
Okay, so here's what.
Why don't we haven first?
Yeah, let's do the havening exercise.
Fine. Perfect. So here we are. Cortex, the context. Remember what that was? Cortex, complex content, goes into the recalled event for working memory. The hippocampus remembers it. It goes into the basolateral complex of the amygdala. Havening acts here. The amygdala is deactivated, and the pathway is depotentiated, and that's how it all works. Does anyone have? I'm done, by the way. Does anyone have any questions? Is this mind blowing?
In my view, there is a missing link. The delta wave creates this depotentiation, yes? But then the touching is the one that is producing the delta wave?
Yes. And also GABA. GABA medium computer.
But it's the touching.
Yes, GABA because of the increase in serotonin which produces GABA. And the eye movement also creates delta waves. 1 to 2 hertz delta.
Then the touching and the eyes movement and creating the delta wave and
Yes.
GABA.
Yes.
And with that, you create the depotentiation.
You create a depotentiation through calcium which depotentiates the AMPA receptor.
Now, why detach over here and over here?
Well, because I showed you that the delta wave production touching those places is 90 times off baseline. It's the highest areas that you can touch.
By the way, every traumatic event goes to the amygdala,
Every.
bypassing the hippocampus.
Well, again, all these things are coordinated. The hippocampus in traumatic memories, PTSD, for example, the underlying neural landscape is so disturbed, the retrieval and the storage is so distorted. That's why you have flashbacks. That's why you have numbing. That's why you have night terrors. That's why all those things, which I could explain, which is in the book, so we can readily treat PTSD, just like we did here.
Yeah, let's do it, so that you could be part of the questioning in a little bit, but
Okay.
maybe we could
So,
get through this.
Everybody, you all got this?
Yes.
Okay. Let's, everybody just get themselves comfortable in a chair, put the books down, uncross your legs. Now, well, you know, and you don't have to write the numbers, but what I'll do is at the end of the process, I'll ask anyone if anyone's gone from, and what's nice